Good afternoon, everyone. We'll give a few more minutes to allow those to join who are in the process. I'm glad you're here.
All right, Co-Chair Richardson, I think we have everyone in. I know we have a quorum, so I think we can get going.
That's great. Thank you, everyone, for joining this afternoon the Universal Health Plan Governance Board Transition Committee. I don't see. I don't see everyone. So welcome everyone who is here. I appreciate your time this afternoon, and we'll get started right now. And welcome those who join later. Uh, as a practice of tech check, let's do a roll call. Lee, can you help me out with a roll call this afternoon?
That's okay. I've got the
Amy,
list. I
thank
Yeah,
can
I was
take
gonna say I
care of
don't
it.
have the list on me
I
actually.
do. All right, everyone. So good afternoon. This is Mimi McDonald, and uh, Isabel is not here. So apologies in advance. Happily, she's taking some well-deserved PTO. So when the screen goes dark, it's all on me, but I'm going to try not to do that. All right. So roll call. Judy Richardson.
I'm here.
Excellent. Mike Leahy.
I don't see Mike.
I am actually not seeing Mike either. Okay, we'll leave a little empty space for him. Mary Lou Henrich.
I'm here.
Excellent. Anne Lovejoy.
Here.
Thank you. Doris Karagu. I'm looking. I don't see Doris's name just yet. Charlie Swanson.
Here.
Thank you, Charlie. Richard Gibson.
Here.
Thank you. Jamie Osborne.
Here.
Excellent. Eve Gray, I know was going to be absent. Mickey Dirting.
Here.
Hello. Jensina Hawkins.
I
Go
saw
through the
her.
list. I thought I saw her too. Hold on. And it looks like she's a co-host. Jensina, are you here? She may just be off. I mean, I see that she's somewhere in the meeting. And not on mute, so we should be okay. All right, well, I'll come back to her. And then Tony German.
Present.
Excellent. Okay, that is everyone.
That's great. I want to thank everyone again for your time this afternoon, the time that you've put into preparing for this meeting, and I will turn it over to Director McDonald for board updates.
Oh, did you want to do the agenda?
Sure, here's the agenda. We're gonna, in a moment, spoiler alert, we'll talk about board updates. But today, really, we're going to hear a lot about the IT blueprint. This is for information and discussion. We'll get to see the information system presentation that operations saw a while ago. It feels like ages now to my operations friends who are on the transition committee now. It'll be a nice refresher. And for those of you who maybe missed that presentation during operations, this will be a treat. Then we'll launch into the prescription drug strategy, start thinking about how to frame up. We will be led by Lee through that presentation. Then we'll revisit our transition roadmap just to discuss the transition roadmap memo and the launch canvas. wrap up with any member reflections, any homework, perhaps a look ahead for what to expect next. We have a board meeting and another transition committee meeting, and this train is barreling down the tracks. We'll finish with public comment and appreciation for the public who has been engaged and providing comments all along. Thank you. Now, Mimi, board updates.
All right. Well, again, thank you. It's Mimi McDonald, Executive Director. So just some brief board updates. Next board meeting is next week on Thursday, June 18th. We already, since this group meets sometimes before the board has a chance to meet again, you guys already heard about what happened at the last meeting. So I'm going to tell you about what's upcoming. There will be an update on the expenditure analysis from Milliman that a lot of folks from the transition committee have been helping with, and also Chair Belanca. And so I think that's going to be really interesting. There will be a vote on some additional portions, some specifics on the revenue plan. Our good friends at Echo Northwest will be providing, they've been pushed back a couple of times, but they really are going to talk about reserve funding strategy. Lee Hastings will be presenting on which this group has already seen governance and statutory gaps for a vote for the board. And then also, again, what you all have had a chance to weigh in on is the implementation sequencing. It's really going to be a discussion that will come back again to the board, but just to give everyone a heads up of what's going on. Just as a reminder, we still have an open board position. So this is for a community engagement spot. We're really excited about the folks who've applied already. Applications need to be in by June 22nd. And then there will be a list that goes to the governor's office. The governor's office is the group that actually decides who they would like. And then that whoever we're choosing two, one to fill the slot that's going to be vacated by Michelle Glass, and the other to fill the spot that's going to be vacated by Amy Fellows. And the list will go to the governor's office on July 1st. So already excited about the folks who are gracious enough to be willing to do that work. All right. So I would like to bring to this group's attention, we're going to talk about information technology. Obviously, this is a massively long topic, and you could have committee meetings from now until the cows come home on this topic. However, really what we're thinking about here is what I would like to do is kind of frame up the discussion for this group to see what this group and their expertise feels is appropriate to weigh in on. And then, and also, again, as usual, thinking about topics for further exploration and kind of I would say like the direction of those topics, because of course we know don't have the money or the expertise to do a very, very thorough job of developing an IT strategy or the time. So this is really an opportunity for folks to, kind of think about what's been happening. I included, apologies for including so much in this for this committee meeting, but I included sort of the full length operations committee presentation with all the acronyms and all the everything's on it. And also something about how some of the information technology strategy that's been happening in Washington State, just as an example. So starting off with this framing the discussion, again, kind of if we sort of bring it back to what the Universal Health Plan Governance Board needs to be doing and what needs to be in the report that goes in front of the legislature. So in the ORS, creation of a comprehensive plan to finance and administer a universal health plan. Now, an IT system strategy is not specified. However, it would be impossible to administer a universal health plan without an IT system strategy. So obviously within that, sort of maybe not spelled out, but it is of course necessary. The Amazing Operations Committee had hoped to have the time to get to this. So when they created, this was a couple of years ago when they created their work plan, they had hoped to be able to get to like a cost benefit ratio of a statewide health information system and provide recommendations for IT needs and requirements. And that did prove to be a little bit over ambitious. Just timing and all of the things and when things got started, so that that part of the work plan, despite all the work of the operations committee, was not able to be completed. And so for this committee, the kind of the question is, what can this committee, what can be developed and what kind of input can come in from this? So, in the IT strategy scope, and again, this is all up for discussion. I'll tell you kind of what I highlighted, what I think would be really helpful from this group, especially because it's such a diverse group, is thinking about the desired future state. And Co-Chair Richardson helped a lot with that. So in other words, you could dream up what would be the best thing for a universal health plan or the best thing for Oregon in general. What would it look like? And then, of course, guiding principles, because we know there's so much going on right now with IT and AI. And I think really making sure that it's still grounded in what is important and the premise of, the thought of doing no harm, because there's definitely always an opportunity for that. Other things that can be included, I mean, again, this would just be sort of a strategy draft, is thinking about, what groups will be the partners, what ecosystem exists already. Those are things that we can find out and be able to put into it. The next bullet point, a target enterprise architecture outline. I'm not sure. It sort of depends on where things get in the discussion, and that may just be something that absolutely needs to be put later. Data governance and privacy outline. There are a lot of regulations and rules and best practices that are available. And again, the whole thing won't be built out, but the ideas around it. And then another very interesting concept has to do with financing and authority potential. So especially on the financing part. So those are all things that are things to consider. And then definitely future evaluation. By future, I mean, possibly 2027 and beyond. Much more into the weeds of, structure of the development team, financing authority decision, a very, very, very detailed financial analysis, and then a roadmap and specific recommendations. So it's a whole big laundry list. But I'm wondering if people have strong feelings about if something is missing or if any topics should be moved, like the only thing we can do is the first 2 bullet points, or there's something on the bottom that, like, no, I really think we need to at least bring up as a topic in a report that goes in front of the legislature. Mary Lou, please.
I guess the partners and ecosystem, I think that, as far as I know, and I actually have asked for a list and think I have a fairly comprehensive couple of lists now of all of the providers, major hospital providers, as well as clinics that are currently using the Epic system. And it's been said, and I don't have this verified, that between 75 and 80% of all of Oregon provider system is currently using some form of Epic software. And it seems to me that we need to really have that listed, because as I listen to discussions and have listened to some past ones about kind of people saying, oh, well, look at what terrible thing happened when Cover Oregon happened, or look at the terrible thing that happened when the DMV did their thing, or that Oregon has a bad history of doing IT, big IT things that cost overruns and just kind of big messes. And I'm kind of going, well, those are all, probably about 20 years ago, at least. Things have really moved forward, and that in healthcare, my understanding, every nurse and doctor and everybody I keep talking to says, oh, we use Epic. Oh, we use Epic. Well, so I don't think we have to invent it. We need to look at who doesn't have it and how much would it cost to get them into it, or some, as they talk about these words, interoperability, if they didn't want to switch or whatever. But it just seems to me that we're 20 years down the road in terms of the market. Things have happened, and Oregon is pretty much an Epic software state. So I don't know where that fits in here, but I think somewhere that to me is kind of the partners and ecosystem.
Yeah, thank you so much, Mary Lou. And also, one thing, just, and I'm sure that probably other people are thinking of this too. We definitely want to think about the provider side, absolutely. But there will be that interface if we, and again, using broad terms, thinking about a universal health fund being like the payer side.
Yeah.
So it's something that is
Yes.
not necessarily synonymous. But
Right.
I think Richard, your hand was up next, and then Anne.
Yeah, I was going to continue with that idea. A couple things. Number one is Epic is largely a provider clinical system, but that's not what we're doing here in this with Universal Health Plan. We need a full claims management membership
Yes.
recovery, and that's really different from, I know that Epic has billing modules, but we're not talking about billing. We're talking about setting up an entire insurance system. So I think we're getting waylaid to looking at Epic, there's a confusion between an electronic health record and a system to set up that does billing and keeps tracks of payments and can do subrogation and deal with other states. A completely different system. The second thing is a lot of the health systems have Epic, but a lot of the providers don't have Epic unless they work for a health system and have their electronic health records for that. So we still have a lot of providers that are using smaller systems that are not Epic. And we need to look to the national interoperability standards so they can submit their bill. But I would say let's focus on how we get bills out, and how we get claims coming in and payments going out. Thank you.
Thank you, Richard. Anne.
Yeah, I just want to echo Richard and also Jacina that we don't want to dive for an easy solution. If we want to actually look at requirements and we want to look at the interoperability, and we also want to keep the claims payment in mind.
Excellent. Thank you. And Mike, please.
Hi, and I apologize. I'm having technology issues here. Actually, Epic has a robust system called Tapestry for health plans that many providers and health plans use. So just I don't think Mary Lou was strictly talking about just the EMR. There are different modules of Tapestry, if you will, and of course Epic is in systems now developing in Singapore and Washington and many other places, and that's not just the EMR. That's it's the entire interoperable system.
Thank you so much. And I am going to read from the chat. So first from Jensina wrote, I implement EMRs for a living and I represent probably 80% of that 20% not on Epic, but getting practices and healthcare systems to transition their computer records is a huge undertaking, and the cost is not only financial. Mike put in Epic has Tapestry, and Jamie put in also Epic has dental and pharmacy potential. However, Epic is not Epic. Yes, each vendor and system is unique. So I think that's also an excellent point. And Tony, please.
Yeah, this is a great conversation and kind of prompting some thinking around this. I think the desired future state is key, and I think defining that better. In Richard's comments stood out to me in that there's a lot of things I think we would want. What do we need with implementing this out of the gate and thinking about those startup costs? And so I think distilling that down a little further would be good for our conversations and the reality we face with the concern of upfront costs. And I think stripping that down to really the interaction that the patient faces with the health system, and ideally having something that would be simplified. A lot of other nations have just their identity card that it starts the process with them, their access. But then the health systems, a lot of health systems already have their IT infrastructure. They already have a great deal of staffing related to that. I would argue that in our space, this really isn't the place to take that fully on. And I would caution us a little bit about that. Ideally down the road, I think the other clarity is the interoperability. One of the things we're going to see on savings and redundancy in the system is the ability of something like Care Everywhere that is in Epic, or other things where we can see that patient had that MRI over at that facility at that time point. I don't need to repeat that study. I don't need to repeat that laboratory that was done. I think that that's an important piece. But I think in the process that we've reached that, I think the claims processing, I would like to have it all, but I think in the pecking order of things, I think us putting that in order.
Thank you so much. Paula, please.
Yeah, I second that. I think there's other solutions, and the EHRs, I worked for an HIE, and so there's interoperability in Oregon that I think, so, there's other things that we can look at there. And moving providers to a different system is a huge undertaking, but I understand Washington's doing that. But yeah, so I agree with, claims and payment and, priorities of what we're looking at.
All right. Thank you, everyone. This is great, and sort of what I was hoping for. So going on to this is even more fun. So let's think about a future state. This is always the good times when we plan this stuff. So definitely, Dr. Richardson helped a lot with this. And so again, this is not set in stone by any stretch, but kind of ideas. So I think you'll notice the word backbone in there. So a single trusted statewide information backbone that enables the connections, supports global budgeting, quality, payment integrity, probably for just about every group, minimizes administrative burden on providers, I think is crucial. It's part of it. Possibly even more important, preserves user trust, patient consent, and data protections. And then, and some of this is taken from the Oregon information technology, provides an accessible, simple, engaging, and reliable interface for all Oregon Universal Health Plan participants. So I think that was a little bit, Tony, about what you were getting to, is like there's so many facets to it, but we have to think about, or it needs to be thought of who is using this, all sides of it, and who it's for, and how you can enable improved healthcare, amazingly enough, by having good sites like this. And I think Charlie was first, and then Richard. I looked away for a moment.
So I want to re-emphasize a couple of things that Judy had put on there. One, the second statement of supports global budgeting. That's probably going to be a very different sort of thing than what existing Epic systems do, and I think it's really important for the system that we would would be ideal, that it does a really good job of that. Another thing I think that's going to be really important, I expect that Oregon's system is still going to have to report things to the federal government in order to continue to get federal money. It's probably especially true for Medicaid. It might be true somewhat to Medicare. And so the system that we would like would do that very readily, automatically, hopefully, or something close to that. Another piece that I want to emphasize that Judy put on there is preserves user trust, patient consent, and data protections. So to me, ideally, patients would have access to their records, and the system would allow that in a reasonable manner. Another thing is patients, I think, probably need some control over access to their own records. Not every provider needs access to all this stuff. There may be things that patients want to have access protection for. So I think that's potentially an important piece. So mostly to emphasize what Judy said, with an additional thing about federal government reporting. Thanks.
Yeah, thank you. Reporting, that is such an excellent point, really crucial. Richard, please.
Yeah, I think again, we're expanding the scope of what's needed here. We're not, in my opinion, we're not building an electronic health record. We're not building an information backbone. We're not doing clinical work. We're not doing public health work. We're not doing social care in terms of being the system of record for that kind of patient care. Our job is to sign patients up, sign members up, accept claims from providers and get them paid, and then do all the accounting, as Charlie said, with the governments that need those data. But to think that, health information exchange is closer to an information backbone than what we're trying to build here, in my opinion. So again, I don't want to conflate what we're trying to do for the universal health plan with the general electronic health record that patients need access to their clinical record through. That's already handled by the providers and the provider electronic health records. So patients need access to their claims. That's a different matter. But again, I'm careful about not conflating a clinical record with the claims record. Thank you.
Again, I'm wondering, not to put you on the spot, Judy Richardson, but would you talk a little bit about kind of what you're thinking? And I appreciate that comment, Richard. I think that's really scope creep. It's always.
Yeah, thank you for the comments. And I agree. Really, my goal with all of these is what is the minimum necessary requirement, right? And then I started thinking a little bit beyond that. So if we have this minimum necessary requirement, what's the easiest lift? Is there any low-hanging fruit that we could also leverage and benefit from, short of a statewide clinical electronic health record, which would be great, but impossible at this point. So that was my intention. And these things were all ideas that seemed to fit in that bucket. So I thoroughly appreciate the thought and feedback and the ability to pare it down to the minimum necessary business requirements to run a UHP. Love that, Richard. And then I was just trying to push it a little bit, the envelope. If we have the bare minimum necessary, is there any other little low-hanging fruit that we could benefit, that would benefit the user-facing interface? And one example is if we have to report any sort of clinical data up to the feds, or track quality improvement, if there's any sort of value-based payment implicit in the universal health plan payment structure, then that's going to need some clinical data. And so that's why I was thinking, oh, but you want to pull it back so it's not an entire clinical record. So that was my thinking. More of an art than a science.
Thank you. Mike.
Sure. I want to build on what Judy just said. I had a conversation yesterday with the former chairman of the board of Kaiser, a guy named Dave Lawrence, and I've been talking with some of the Kaiser people. I'm trying to, we need to figure out the right analogy here, because, I'll go back to, there are various different applications that, and it's the point's well made of, we're not just talking about an EMR, but we are talking about a universal database that we want the universal health plan to have the capacity to mine, to make improvements. So unfortunately, there are not any great analogies here in Oregon. Both Kaiser and Providence have health plans, so they are, two of the systems, and they each use the Tapestry piece. But I think we need to do some more work on this one. I think this is more akin to what's the capability. I don't think the critical thing here is claims, guys. So I guess I'm not totally with you. I think the key thing is connecting Oregonians and providers. And yes, paying the providers is very important, but there are lots of systems that do that. I think we should be investigating how Maryland does global budgeting. I know within Kaiser, having used to run 15 of their hospitals, it was very useful to have an integrated database with the health plan, and we were allowed to make lots of improvements, just like the NICE system in England is able to do by having an integrated database. So I think we need more work on this, and my own sense is I don't think there's any perfect analogy here, because I hope we're not reinventing the wheel. I hope we'll come up with some cost-effective system that will do all of our basics to start, and then add other modules and other capabilities as the UHP develops. Thank you.
Thank you, Mike. Mary Lou.
I guess my thing is that I keep going back to Chun-Wei Chi's description of how it is in Taiwan with, I see this little credit card that has the basic, all the information, so that what I'm interested in is how we can make our system as efficient and effective as possible, which I think is what we all want. And so the fact that whoever brought up earlier in this discussion, the thing of not duplicating lab work or MRIs or things that have been done in one place. And what I found in my just being a patient, very infrequently, but every once in a while, it's like, oh, well, when they changed health plans back a long time ago, it was like, oh no, well, we need to use our labs and redo this stuff that we just did that makes no sense to me in terms of the system. And so I'm wanting to be sure that the savings that we can project in terms of having a universal plan, that we've kind of got the backbone data system that supports that and doesn't have providers needlessly redoing expensive tests and technology.
Thank you. I'm going to read what Jamie put in the chat and then go to Tony. So Jamie wrote, I like the idea of what is the bare minimum in order to start and what is perfect future state. And then thanks for nodding to partnership with Kaiser. They have great examples of how to connect claims and quality improvement. Thank you, Jamie. Tony.
Yeah, I think I'm in agreement with a lot of statements been said. I just wanted to clarify my comments earlier. I think keeping it simple out of the gate, but I think that this endeavor, there's a lot we can do. I think in getting the governance board and that report and the total cost, I'm just cautious about the whole kettle of fish and thinking of, it'd be great we had one EHR. It would be great if we get that one card like France and Taiwan and all of that. I just worry about this report coming so quickly and the content. Now, what I would recommend to the governance board is to say, these are the ideal settings. And I think that's what the desired means. But as far as the deliverable in the actual item for us presently, I don't think we're there yet.
Thank you. Those are all really helpful. Let's see. Oh, these are just some of the, I told you I looking at Oregon's strategic plan for health information technology. This was developed a while ago. And I think that, again, if people are, it's always hard to think of what isn't there, but guiding principles, people first, equity by design, and then of course that privacy and data protection, interoperability, talked about that, zero trust security, which sounds a little more ominous than it is. It just means everything must be verified, which I think we can all understand that. Observability and outcomes, I think that's kind of getting to some of that quality work that we're talking about, sustainability, transparency, modularity and reuse, and improved efficiency. And I think that I really like the fact that I think it was Richard who called out, or Charlie, making sure that it has that ability, that sort of reporting ability, that is really crucial. And that is can be the downfall of many things. I don't know, maybe reportability isn't a guiding principle, but I appreciate that. And again, I'll just take a second. If other folks, when they've been thinking about these things, Anne, please.
Yeah, you just want to add audit ability to your list because there's a potential for fraud.
Thank you so much, Anne. Always the voice of reason and rational thought. I appreciate that. And of course, people, you're thinking about this, you know, other things or other resources as you're going along, because there's so much that goes into this. And we're doing pretty well for time. So these are some questions for you. Again, sort of ideas to kind of kick around, because we will come back to this and you're always happy to email, you know, what else should or could be included in a desired future state. And I think that is that, I like the idea of the presenting, you know, sort of the minimum required product and also ultimate where you would want to go. Are the guiding principles that we have in here sufficient? And then, okay, this is just a bonus question. We don't have to get into it today, but who's gonna implement this information system and administer a universal health plan IT system? Should that live within the universal health plan, you know, structure? Should it be outside of that? And who decides that? So that's kind of a big question, just for fun to think about. And Mary Lou, please.
I guess I don't think it's that big a question, or that in my mind, it's clearly that the public corporation has that under it. So I guess maybe I've just been kind of going along assuming things, and you know how much trouble it can get people when you assume things. So anyway, I'm just kind of going, oh, wouldn't that just be, you know, a part of what the public corporation does? So anyway, that's just my thought. I mean, I don't know who else would do it. Certainly not OHA.
Judy.
Thank you. I'm wondering, along the lines of efficiency and effectiveness, if there's something existing that does work well that might be used, like the Oregon MMIS, for example. We haven't talked about that really.
You're right.
Just curious.
Yes, kind of use what you have and looking into that. Yeah.
That could be transferred. Mhm.
All right. Well, I thank you guys all for an amazing discussion. Oh, also Jamie put security infrastructure will be very important. A single program is more vulnerable to cyber attack. That is very true. You need even more than belts and suspenders. The whole shooting mess. Okay. Again, thank you. We're gonna move along here. Oh, just to let you guys know what's happening. We're going to talk about this again at the July 9th meeting. If you have any resources, subject matter experts, I have to say I did have one committee member already who was willing to jump into the ring with me. And so I'm super grateful. Richard Gibson, who has incredible background in this. And also I dragged Mike Leahy into it too, whether he didn't volunteer, but he was voluntold to come to the meeting. So if anyone else is interested, please let me know, and or just anything you like. Okay. All right. I am now happily going to turn it over to Lee Hastings for shifting gears, talk about prescription drugs.
Great, thank you. All right, yeah, I think we can dive right in. So our discussion today, we're going to be talking about a prescription drug strategy, and this is really kind of an outgrowth of what we've already talked about related to cost containment. I don't actually think this committee has talked about, but the board has talked about it. Other committees discussed this issue. So we're not starting from scratch. That's the good news. We are building from some of the pharmacy-related cost containment recommendations that the board has already approved. From this, we're going to talk about, you know, what a prescription drug strategy could look like. And this is another one of those two-parters. We're in part one right now. So there's going to be some homework where I'm asking you to consider that minimum viable prescription drug capabilities for launch. So similar to the IT conversation you just had, there's sort of two different things happening. We have, you know, a big prescription drug strategy, which is actually fairly well defined based on the recommendations. But what we're really asking of this committee is, what does that minimum viable look like? At what point do we think that we have something that is solid enough that we would want to get started with this and allow that transition to occur? Next slide, please. We don't need to spend a lot of time on this. I think we can all appreciate why having prescription drug strategy is good. Prescription drugs cost a lot of money, 16% just for that retail pharmacy. And that's not even including the drugs that are administered in facilities. The US, of course, spends an inordinate amount of money on prescription drugs, far more than its peer nations. And we know that a lot of folks struggle to be able to afford their prescription drugs. And, polls indicate that there are many Americans that take measures such as skipping doses or cutting pills in half, things that we really don't want folks to be doing in order to maintain affordability. Next slide, please. So just worth noting that Oregon does have several things in place. This is not all of them, but these are some of the key infrastructures that we do have available right now, kind of split between DFR, which regulates sort of the insurance side of things, as well as OHA. So we have our prescription drug transparency program, which requires drug manufacturers, PBMs, and others to submit information related to price changes. So they're really concerned about, changes year over year, certain high cost medications, et cetera, trying to contain costs through that sort of transparency. DFR also has the Prescription Drug Affordability Board, which undertakes kind of broader reviews. So the transparency program is really sort of, drug by drug. The Affordability Board is taking kind of a look at the pharmaceuticals sort of across the board and different strategies. They issue annual reports with really great recommendations for cost control at a system level. Within OHA, there is, of course, the Oregon Prescription Drug Program. This is a state-run prescription drug assistance program that is actually part of a multi-state purchasing collaborative that's known as ArrayRx. So one way that discount prescriptions can be available to folks that are maybe underinsured in this particular area. And then also, as part of its Medicaid program, Oregon does have a preferred drug list that it uses for outpatient drugs, meaning, in terms of some of the things that we'll talk about, we do have a starting point for a formulary. As far as Medicaid, those preferred drugs generally have no prior authorization required, which of course is a nice bit of administrative simplification on the provider side. Next slide, please. So these are I always get confused if it's 6 or 7. I think it just depends. Some of them I sometimes split up, but around 6 or 7 cost containment recommendations that the board approved related specifically to prescription drugs. And hopefully none of these are brand new to anybody. There's a lot of common ideas here, having a single formulary to really prioritize the use of generics, some tiered pricing potentially, kind of a whole strategy around PBMs or pharmacy benefit managers related to transparency about maybe the ways in which they're potentially steering patients, their role, and potentially long-term plans for the state to take over that administration. There's also this idea of upper payment limits, which, just as it sounds like, would cap payment limits, and then exploring strategies related to specialty drugs. Charlie.
Yeah, I'm gonna go to like point number 4 about PBMs. In many ways, this state could make use of ArrayRx as the PBM. I mean, and so an advantage of doing that, especially if it had expanded staffing and a few other rules and regulations. But the advantage of that is it's already multi-state. And so we would gain more lives than just everybody in Oregon if we went that direction and eventually move forward and other states move forward as well. So to me, I think we should think very seriously about what can we do to increase the efficacy of the current Oregon prescription drug purchasing program and make use of that expertise and interstate capabilities within the UHP. And so to me, that could also move forward independently from the Universal Health Plan. So I'll stop there.
Thank you. An excellent point. Appreciate it. All right, so oh, I thought I saw another hand, but I don't think so. As we kind of consider all of these, there's a fairly robust and fairly clear kind of long-term vision here for having that strategic pharmacy governance, a lot of transparency, clinically informed evidence-based standards, and above all, that sustainability of the spending with the capabilities that have really been outlined, strong analytics, that centralized formulary is one that came up a lot. Consolidated purchasing, whether through ArrayRx or anything else, but that being pretty central, and then that specialty management. Next slide, please. All right, so as you look across, how different nations and places that manage their own healthcare systems deal with prescription drugs, there's sort of these three operating models. And I just want to note that they're not independent operating models. You can work across all of them. They're just slightly different philosophies for how you approach your prescription drug management, and you can absolutely, pick and choose from the different buckets. So under a governance model, you really have a goal of influencing your utilization, and this is something that relies really heavily on having that centralized formulary and strong generic first policies. There's also operating models that really lean into the purchasing side in order to contain costs. And the goal here, of course, is lower prices, really talking that lower per unit price as opposed to overall. Example tools for this, Oregon has its prescription drug purchasing through ArrayRx. This is one of those tools. And as Charlie mentioned, and I think was also mentioned then again in the comments, that we can absolutely build from what we have. I agree that that is probably ideal for us to do, but also bulk purchasing, bringing together more payers. For instance, currently in Medicaid, all of the CCOs do their own purchasing. That's something that could absolutely be consolidated, as well as, OAB and PEB and other state agencies. So lots of possibilities there to consolidate purchasing to improve that ability to negotiate. And then there's also the management, and this is the most complex, but it also does kind of give you the broadest control. And these are techniques to manage total spend, things such as implementing those upper payment limits and having those specialty drugs. And as you can see on the bottom, I just sort of assigned the alignment to our recommendations. We have some alignment across all three of these. So next slide, we'll take a look at how these models interact with those recommendations we have. And really the primary takeaway here is that we have recommendations that span across all of these. And this is, I think, a good thing and a very reasonable thing, because when you look internationally at how countries do this, you see a very similar model where they show up in multiple different operating models. Essentially, they're using multiple levers to help control their prescription drug cost over time. So, this set of core strategies that we have here, it's pretty solid, and from looking at international data, certainly seems to be pretty robust in terms of addressing these different areas that are available. Next slide. So now as we start to talk about what does this mean in terms of, this committee's work, a transition strategy, these three operating models have different levels of complexity, of course. And so one way that I thought to present them or to think about them was operating in stages. And these arrows overlap, and that's intentional because you could be implementing these stages simultaneously, just knowing that they are slightly different work streams, and therefore would probably be finishing at different times and not, operating in parallel as opposed to intersecting. So that pharmacy governance, that's some of the most straightforward. That's, again, really about understanding and influencing that utilization. And this is really where you're strengthening those analytics, looking for that transparency, trying to understand what is driving folks to, some of the higher cost drugs that we know account for about 80% of our price, or our costs, excuse me, even though they're only about 10% of what is prescribed. So really trying to understand and reinforce generic first policies, and doing that through the means often of a formulary that supports those policies. Stage 2, a lot of folks at this point start to get into that consolidated purchasing. So really trying to leverage that, that purchasing power to drive down your per unit costs. And this can be done, first just by having lots of partners. It can be done through PBMs as well, and it can be done through having various kinds of preferred products in order to really, increase the amount that you are purchasing maybe of high volume drugs and get discounts in that sense. Stage 3, I term this centralized administration. And this is where people start to think about, kind of becoming a PBM, so to speak. And I do just want to be clear that pharmacy benefit managers are really just a US kind of phenomenon. So when we do look at these other countries, we're not really talking about PBMs. If I use the term, it's more talking about how do they manage their pharmacy administration. And so it's starting to get into that space. There's always the possibility, because we do have PBMs in this country, of maybe having a preferred arrangement with one, or the possibility of, building out the public corporation's own pharmacy administration management. And this, of course, being the more complex, has the longest timeline, somewhere between maybe 2 to 5 years around here. And specialty drug management would also fall within this realm because of the high complexity. Charlie.
So I would suggest that one possibility that would, in my mind, simplify some of this as we're moving forward. Again, going back to ArrayRx, so the public corporation could become the place where the Oregon part of the management of ArrayRx lives. I mean, that would be one possible way to move forward. And then you would be making use of the expertise that already exists there. And I think the timeline could be shorter, and it could also be independent of whatever happens with the rest of the universal health care plan. I mean, now, again, recalling that ArrayRx is not just an Oregon thing, so that the public oversight, I guess, if you will, involves other states. But in my mind, that's a good thing. So again, I'll stop there.
Yeah, thank you. And I think it raises a really great question about, that level of integration that we want with the prescription drug program. Richard.
Yeah, my point of view on the drugs is that it's not necessarily part of a universal health plan. Meaning, if you said, I'm building a single payer plan and never address pharmacy, I'd say that's fine, you're building a universal health plan. I think that the reason why we're interested in pharmacy is because it's 16% of the budget and it's growing fast. I'll bet you in 5 years, it's 20% of the budget. They'll take all the money off the table. So it's important, if we're on the hook, meaning taxpayers, not employers, and private insurance plans, if we're on the hook for it, that's why we need control of the cost. So I think that's why we're involved. So I think it's important to keep it separate. Second thing is that this pharmacy program could exist without a universal health plan. And I'd say that it needs its own effort right now, and it could work in a multi-payer environment like we have right now in Oregon. So my thing is, if I were king for a day, I'd say, let's not let the pharmacy program wait for the long rollout of UHP, which is even more complicated than single pharmacy. I think we need a new legislative effort parallel to the UHP, but separate from it, to build a single purchasing plan for pharmacy, regardless of what happens to the UHP. And I think it needs its own launch, its own legislative effort, its own advisory board. Sure, we'd want to keep track of it as we're building the UHP, but I don't think it's ideal to put pharmacy inside of the UHP because it's a completely separate effort. It benefits the UHP, but it needs its own legislative roadmap, in my opinion. Thank you.
Thanks, Richard. Mike.
Yeah, I want to kind of build on Richard's piece, but I have a much more fundamental thought. At some point, we need to think about RX and IT and claims in terms of what is our vision of the universal health plan. I think the fundamental vision is that it brings Oregonians and professionals together. And so the core of this to me is governance. it is not clear to me which of these functions should be within the UHP and versus where they partner. My second comment is that let's be cautious about jumping to things without looking at size. And this is where core competencies come in. And this is not any critique of array drugs, but we have within Oregon, we have a national organization called the VA that has pharmaceuticals. We have an organization like Kaiser that has over 11 million lives. And I do want to point out that array is a wonderful idea. We should consider it, but even in multi-state, it's got, I think, just short of 1 million lives. So the economies of scale, I think, should be at least considered. And that goes back to Richard's point of we should further discuss this, but it may well be that we want pharmaceutical governance and some structural things within the UHP to be able to figure out, what drugs are covered and what's in a form. There's some basic governance and architectural things we need to get at. Whether or not we want to develop the competency within UHP for pharmaceuticals versus partner with Array or Kaiser or VA, whatever, I think it is a secondary consideration. I think we should be focusing a lot on the governance of this. And Richard's point is so clear that it's the drugs are the big cost thing, and it's not regular drugs, it's specialty drugs that we're
Yes,
concerned about.
yes.
Thank you, Mike. And I'm not sure how much Array covers, but I can see that through the Oregon portion is about 300,000 lives.
Yeah, it just doesn't compare to Kaiser with over 10 million or the VA. It's not a big player yet.
Right. Thank you. Jamie.
I'm not an expert in 340B, but we have to acknowledge it. And I also, and I'm the queen of weird ideas that please shoot them down because that's good. But is there an opportunity as a state to look at 340B as a potential way of doing this? 340B has federal support for FQHC, usually FQHCs, but also hospitals, to be able to offer medications at lower cost. And there's the potential for a pharmacy plan to undermine that, and there's a potential for it to build on it or to run beside it. I just don't know if anybody's ever explored, could we do it at the state level? And could that become a source of income that could help with some of these transformational efforts? Again, I'm not a person that can answer it, but I'm just going to throw it out as a weird idea.
Thanks, Jamie. And it's on the last slide, but I do note 340B is one of those areas for further exploration. Charlie.
Yeah, so I just want to go back to the ArrayRx question. It's not how big ArrayRx is now, it's how big it could become, and in my mind should become. So I think we need to be thinking about, well, what could happen, and what are the capabilities of, how we could get it to happen. Partnering with Kaiser might be good if Kaiser would want to do that. Now, I'm not quite sure why Kaiser would want to do that, but we can be talking with them and find out. So, I think any time that you can get a large body of the population of the U.S. Working together to try to get lower prescription drug prices, that's a good thing. And I just think that the way ArrayRx is set up, it has that possibility sort of almost automatically to do that. Not necessarily will do that, but it could easily become that if we provided support to it, or we as in the state of Oregon did so.
Thank you. Mary Lou.
I was just going to mention that I met briefly with Michelle Coder, who is on that pharmacy board that Sarah Young is. I can't ever get its name down. You had it on the slide back there, Lee. But she is pretty much an expert on 340B. And issues that she was explaining to me that right now at the federal level, there are really potential changes that could dramatically change, for better or worse, 340B and what it's become. But I do think if we want somebody to talk to as a pretty much expert on this 340B, because she's the chief of pharmacy at Multnomah County, which has, you know, the huge FQHCs. Anyway, Michelle Coder is her name. She was very helpful. And at least, I mean, this whole thing, and then the other thing that somebody brought up, maybe it was Mike, but the also talked with another pharmaceutical consulting firm kind of thing, who just said basically the issue is specialty drugs. That, and I had never even kind of heard of specialty drugs, but you know, they're not things you buy at Walgreens, and you get them through providers. And there's a lot of, that's where the big growth is and the potential. And the last thing I'll say is, I was on a webinar about international universal health plans, and both the United Kingdom and Canada were presenting. And at the end of it, the United Kingdom said, well, the latest, what is it, where tariffs are put, you know, I'm struggling for the word, guys, but where countries do trade agreements, that apparently the latest one from the federal government to the UK has in it, slipped in a little thing that says, in order to have any trade between the United States and the United Kingdom has to pay an additional $1 billion to the US pharmacy companies, or there will be no trade between the UK. I mean, that's, so you wonder how many of these kind of bigger things that are going on have these kind of things slipped in, because it was like the UK has done a great job, but now the United States at the national level is saying, you can't play that game. You just have to hand us money. It was really distressing.
All right, thank you. Not seeing any more hands. We'll go on to the next slide. All right, so it wouldn't be me if I didn't give you some homework. And something that is sort of embedded in here, but that I probably should have made more explicit, especially given our conversation today, is that question of whether a universal health plan should try to take on these capabilities, or whether the goal should be to find a partner who effectively manages these in parallel to a universal health plan doing kind of the primary medical benefits. So the questions are, what pharmacy capabilities should be in place at the time of launch? And I would just add, you know, in place within a universal health plan, or in place with a contracted partner, perhaps. And then what pharmacy functions should remain delegated versus administered directly over time. So I guess I did get to it a little more directly in my second question, but just curious for folks to think about, you know, do we think that maybe these three primary functions of the formulary, that consolidated purchasing, and some of the administration, you know, should be delegated out and should remain delegated out? That is what we're really going to discuss next time. And I'm going to try to look into 340B so that we can incorporate a little bit of that. And then just one more slide here. Just to note, this is a complicated topic, and there are many things we didn't get to. 340B is at the top of the list. Specialty drug strategy is right up there as well, because this is something that is extremely complicated. So not that we're asking this committee to look at, but just wanting folks to know we are aware that these are topics that we're going to get to in the future. And then other federal issues that could complicate implementation, such as any policies related to Medicare Part D or Medicaid-specific drug requirements. And unless there are any further questions, I think we are done with this topic. Great. Back to you, Mimi.
All right. Thank you, Lee. So I definitely have to thank Mickey Durding for this next topic. And Mickey has asked for me to present it, but so anything good on these slides comes from Mickey. Anything that looks a little sus might be mine. So I want you to know, and I hope you'll jump right in, Mickey. But I hope everyone had a chance to read some of the attachments and things that Mickey sent along. And I just think it's a brilliant way to think about this, our transition roadmap. So I'm super grateful. And so what Mickey brought up is, you know, because of course we've talked a lot about these dependencies, and we're even talking about them in the context of the pharmacy and things like that. And I think that her question is like, as we're thinking about these, are we clear about what we're looking at? What is this implementation framework before we start putting recommendations on it? And I think, you know, one of our first points is there's a huge difference between startup assumptions versus steady state assumptions. There's so much that has to do with involving Oregonians in this process, not just as individuals, but of course as parts of communities and as provider groups and community-based organizations and all of these other things, and a lot of trust building. And how can that be accomplished and run in parallel? And this is another good point when we talk, because we talk, and these are all kind of slightly separate, but as we talk about administrative savings, being very, very clear about what is a one-time saving versus what will continue to be beneficial. And I'm going to stop there for a second and see if Mickey, if you'd add in anything there, or anyone else.
No, I'll wait until you're finished with your presentation and then I'll jump in. Thank you.
Okay, that sounds good. All right, so I think this is one of the things that is really beneficial, and we're definitely going to take to heart when developing this transition roadmap, is this an implementation readiness framework. So as you put it, like just essentially a business plan, and bringing it together in one big structure. What are the assumptions that we are making, and just the clarity around that? Again, the easiest example is startup versus steady state. But also, what are the dependencies? What are the governance dependencies? And again, I think that pharmacy discussion was great. Like, okay, what is the role of a universal health plan? Is it truly, maybe we could just get away with governance around a prescription and program, and is it taking on too much to do more? And then other things as well, workforce requirements, technology, all of these things, and of course, you know, reserve and contingency strategy. So I think, and having it sort of in one place is very beneficial. Oops, get that right, sorry. And this is also another concept that I think is very beneficial. So a risk review, structured implementation risk review. So even before you get out of the gates. All right, because it is possible that there may be delays or cost overruns. I don't know, that doesn't usually happen, but sometimes it might. So what could be the causes? How would it be dealt with? And I love this part too, incorporate lessons from large scale organ transitions. I think that is hugely beneficial and an important part of a transition strategy. And then this is also a great point. You know, obviously we have this group of people who are tremendous, and deliberation among this group, I think, really brings up a lot of things, but we also need to make sure that we get those people who have that very industry specific expertise or system specific expertise, and to make sure that when decisions are made, and I love this, assess decision support sufficiency, that the right expertise, the right people are making those decisions. And of course, you know, sort of transparency runs through all of this. And, you know, for what we're doing now, do we feel like the decision support infrastructure is sufficient? And I think that this will sort of be relayed more and more, especially at the board, and bringing back here kind of what the recommendations and the level of the recommendations are going to be within this sort of the report that goes to the legislature and planning for the future. And I put this one in here just because I would like people to think about it. This will be helpful to me, so it's a little selfishly, but like when we think about this roadmap, I think about kind of these different timeframes. You know, we do have that report due, so that's part of it. But then we also have kind of a lovely amount of time actually from September, at least until June 30th, where I know we have funding, about what work can be done in that time frame. And then, and as part of this staff and board working on developing, further work of the Universal Health Plan Governance Board, what would be needed there and what would that look like? So just again, kind of getting people thinking about sort of immediate, relatively near, and then even beyond. I think, yeah, that's really all I had for Mickey. So I'm going to go back to this beginning one and I'll open it up, and let's start with Mickey.
All right. So since we only have 15 and 20 minutes in this conversation, I had a presentation or like talking points, but I'd rather hear from everybody else to see if you read the memo. Did you read the attachment? Did you see the launch canvas? And what stood out to you? Did the distinctions with like startup phase and mature phase assumption resonate? Where are the areas where you felt additional vetting, validation, or analysis may still be needed before the recommendation is moved forward? And then one theme that emerged to me across all three documents is that we've done a lot of amount of work, but much of it has occurred within like individual committees. As a result, we might not have had the opportunity to look across the entire body of work together and examine how the various assumptions, dependencies, financing strategies, operational plans, technology needs, and implementation challenges intersect with each other. And then also to build that strongest possible credible recommendations to the board, would it be valuable if we convened a focused implementation readiness workshop where we bring together staff, consultants, subject matter experts from across the committees and other stakeholders to help us identify that interdependencies, surface any risk, clarify outstanding assumptions, and ensure our final recommendations are informed by a fully integrated view of work rather than a collection of individual components. And then from the very beginning, the first meeting that I attended, I was like, oh my gosh, did I miss a meeting? Because we were looking at like 10 years from now, here's the savings we could have. And I was like, where's the business plan? So that's another question I have is like, do we need a formal business plan? And if so, who develops that? When does that occur? How does it connect to the roadmap? And if there's revenue projections, depending on behavioral assumptions, for example, have those assumptions been sufficiently stress tested under alternative scenarios? Recent Oregon experience, for example, such as a migration effect observed from like Multnomah County, where they took an additional 2.5% income tax for preschool program. And then there was like a migration that happened to other counties and also outside of Oregon. And I'm not saying whether it's right or wrong. I'm just saying, those are studies that we need to also include in our analysis and also recommendation. So what additional work, if any, would help us feel confident that our recommendations are implement ready and not just conceptually sound? And then going back to like, for example, we were just talking about what was the well, let me look at my notes real quickly here. We were just talking about the IT strategy. Like for a business plan, it would be nice. Okay, what is our business plan? Like, our core service is to administer universal health care coverage by managing enrollment, funding pools, claims processing, provider payments, and system-wide financial accountability. And then based on that, we can then look at the different strategies for IT. But right now it's kind of not clear yet. So those are just my questions. So I wanted to hear what you all think as well. Thank you.
You guys know I was so excited that Mickey was bringing all this forward. So I think Charlie, you're first, and then Judy Richardson.
So I really want to thank Mickey for bringing this up and writing it. And essentially Mickey, I think, has pointed out pretty clearly that this is a pretty big job. And I think we do need a business plan. I would like to point out that for a relatively simple project like the Columbia River crossing back in 2013, that the state of Oregon was willing to spend, I think, 175 million, and then the project died. So this, to do the kinds of things that need to be done to create this system that we're looking at, which is actually pretty complicated compared to something simple like the
Build a bridge.
Columbia River crossing. It's going to take some resources, and I mean, I do understand the board's going to have to make a report and figure out what they're going to say in that report. But I think the longer term thing is we need to be pretty clear that this is going to take some serious planning and some serious money if we're really going to get the job done. So I'll stop there.
Well, Charlie's comment aligns with my thinking as well. Thank you, Mickey, for your work. And one of my favorite mentors reminds me, how do you eat an elephant? One bite at a time, right? And so we rely on Mimi and Lee to help us keep track of all of the historical work the committees have done, as well as this committee is populated with folks who've been serving on those committees all along. And so the elements are all there. Yeah, we could put it into a business model canvas. I love doing that because it's so visual and it can consolidate the elements and really highlight where there are missing pieces. But we need to do one step at a time and tackle one element at a time, those things that are more urgent and prioritized, like urging the state to move forward on much of their already existing pharmacy plan is super helpful to us. And I agree, we do need to have an assessment of readiness, but I don't think it's absolutely necessary for us to think about the gap and to dream about that future state. We can do all of those things simultaneously. So I'm saying yes, and it's okay. I appreciate you calling out that there can be pieces that are missed, but boy, Mimi and Lee and Helen and I do a lot of work between meetings to help track and guide and prepare, hopefully to make your time efficient when we're serving on the committees. And Mimi's super responsive at bringing that work forward to help allay fears.
And Richard.
Yeah, I've been involved with Oregon's Task Force and Universal Health Plan since 2019. I've been to every meeting and been to meetings of many of the committees. And I'm surprised at how little I have a sense of what is our legislative strategy for January 2027. I think that maybe that's not in the report, but as we're talking about these general implementation issues, I think that we ought to have a clear idea about what do we take when to the legislature? And to my knowledge, we haven't talked about that yet. Again, it's not necessarily our job, but I'd like to see how that fits into the bigger picture of what are we going to, not just what we're going to tell the legislature, but what legislative process do we want to launch? Thank you.
Thank you, Richard. I'm really hoping that you'll come to the next board meeting. Let's see, I think I'm going to go Jamie, Mary Lou, then Charlie.
Thank you for this. It's so detailed and so thoughtful. And what resonated for me when I was reading the memorandum was you articulated just beautifully the sort of discomfort that I have when I, as a provider, am asked to give my input on something that I have no lived experience about, and a few minutes to prepare for between meetings that doesn't get me into a space where I can be particularly helpful. It's like asking me to fix your car. I can fix your blood pressure, but I can't fix your car. And so I think it's a very important call out to call out our limitations and to request expert opinion, particularly from entrepreneurial places. The second thing I'd say that I'm not hearing called out that really worries me that you mentioned, and I think would maybe come into the idea of the risk assessment pre-mortem, is I think one of the, I don't know that we're the right people to do it. I think we're not. But when we ask entrepreneurs and those with a lot of government expertise, why did something die? We might underestimate the pushback that people who make enormous amounts of money off of healthcare are going to have a concerted, deliberate effort to undermine the success of this endeavor. And, you know, doing a pre-mortem, if we look at this and say, what did us in? It might be big pharma on social media. It might be insurance companies not wanting to lose Oregon as a marketplace. So I want us to think about that. How do we incorporate that pre-mortem, but not to underestimate the type of pushback? I think one of our weaknesses in this structure is that you called together a bunch of idealists to envision something. And we do sort of need a few of those folks who can poke it with a needle and say, you know, that's not going to make it past the legislature, or that's not going to make it past big pharma. We have to have a strategy that includes that. Thank you.
I said, I think Mary Lou and then Charlie.
I was going to just say that, and Mimi, I hope it's okay to say this, that there was a group and there is a group kind of outside of the governance board, but including Mimi and Lee and Helen and Judy, really looking at the legislative stuff, Richard, and the kinds of questions you're asking. So I'm kind of seeing our role here is doing the best job we can to develop the structure of the plan and all the pieces. And I thank for this document that you did for us. It's a little overwhelming, and I read it a couple of times, and I'm kind of going, oh, in between here and there. One of the things I really liked was the fact that just the way the whole thing has been set up with these committees that are an hour and a half long, with presentations, with, you know, it just feels very different than many other things I have been in where I've created things and where there's been, you know, much more time for discussion. You know, I'm not a big fan of all this Zoom stuff. Anyway, be that as it may, we're doing the best we can, and I thank you for it. And I probably need to read it 2 or 3 more times, Mickey, to really kind of get it all in my head. But I just did want to answer Richard that I can talk to you offline if you want. But indeed, I think the strategy that we've been taking is that the board will develop the best plan it can, and that really the advocates and others will be the ones that really are going to create the legislative strategy around it. I don't know, Mimi, do you disagree with me on that?
Well, I don't want to say disagree, but I don't know that that's completely accurate.
Okay.
Just the board will be more involved in that. Let me put it that way.
Okay, that's good. But I do think that, you know, that anyway, I just wanted to let Richard know it's not like there's nobody out there talking about that stuff. And I encourage him to get connected with some of those folks that are.
And Charlie, please.
So sort of building on Richard's comments, and I'm not sure, you know, somewhat thinking about what Mary Lou had said. I mean, among the things that I would expect that the board is going to do is make recommendations regarding legislative strategy that has to do with things that are not necessarily the plan itself. And among those is the question that Mimi had brought up. Well, what happens to the governance board and its financing after or starting in July of 2027? And you know, the board's going to have to be thinking about that, and hopefully they have been. And I'm not sure what the transitions committee's role is going to be on that. But among the other things, again, something that Richard commented on and I've commented on a lot is there could be recommendations related to a pharmacy program or, you know, pharmacy purchasing in general that come from the board, come from within the report, maybe or not. I don't know. So that kind of a thing could happen. There could also be other interim steps that have brought up before related to, you know, does it make sense to think about starting the public corporation fairly soon and having it get some practice in doing things? So there's a lot of those kind of legislative strategy questions for the 2027 legislature that I'm hoping the board has been thinking about, but it'd be interesting to know a little bit more about that. And Again, does the transition committee have any role in that? So thanks.
Thank you all. Oh, Mickey, you were so right. It was such a not enough time, and
Can
we
I
knew that
just
was
say,
going to happen. Please.
so Mary Henrich, I heard one of your comment in one of the board meetings. I didn't watch all of them. I didn't have time to scan through them. And Mary was like, I wish we had a document that shows what we've addressed and what we're still needing to consider. And that was part of that one pager, two-sided. So hopefully it is helpful, and it is overwhelming that it's so true. And then I think Mimi, you wanted to kind of look at it to see what's next steps and what's, how do we prioritize, and did
Yeah,
we give you
absolutely.
enough information or what you needed?
Oh, I think we'll still be able to come back to this for sure. Because it is so rich, and as to Richardson pointed out too, there's so many levels of all of this work, and where things are at. So just there'll be more discussion.
Yeah.
I do
And
want to,
if you thought that was overwhelming, I had more documents. I had like what the task force asked for and where we're at today, and and feasibility studies and risk and all the list. And yeah, so thank you.
no, thank you, Mickey. I do want to make sure that we just have one public comment person, but so Tony, if you want to, if there's something you want to say, definitely have a minute.
Very brief. Great bit of gratitude on the preparation you're making on this. I think it was great. And I think the piece that's standing out to me is the different approaches and the things we need to think about as far as startup, steady state, and the different timeframes and implementation. And I think you call that out very well in this, and stress testing the approaches to those and thinking of the challenges with those. And I think we bring up a lot of those, but I think having it laid out well, I just appreciated your approach to this. So thank you for your work on that. And I do think in having it well laid out would be helpful for us.
Thank you. All right. That's what's happening next time. You had an opportunity to read it. Moving on. I want to make sure. All right. I want to make sure we get to public comment. Hold on. As I mentioned, Isabel is not here. So this will just take me a moment. We had one person sign up for public comment.
While Mimi is queuing up the public speaker, we also received 2 written public comments. So Transition Committee, be sure to read those when you're reviewing the materials. One was from Rick Hangartner and the other from Terry Hammond. So thank you to the public who take the time to write in.
Thank you. All right, Lou, your time starts now. I am not as adept as Isabel, so she's gonna have to, I'll let you know when it's been 2 minutes. How's that? I don't have the fancy timer.
Oh, that's a good idea. Now, let's see, where am I? Oh yeah, here I am. Okay, very good discussion. I really enjoyed the discussion about the IT. I understand, we all want the Taiwan model, which is very nice. The Japan also does do that. You walk in, have a card, the doctor sees where you've been treated on before, and then treats you and then bills off the same card. That'd be really nice. But economy has to be taken in. Remember, we have an extra challenge in Oregon. We're trying to pull one state out of the corporate model and bring it into the service model. One state in a whole country. I don't know that that's ever been done before. Countries have done it, but not one state in a country or one area that I know of. So it's an extra challenge. I enjoyed Mickey's presentation. Also, I read that. I think having a business model only makes good sense. The legislative strategy, I'm sure the governance board will look at that with input. Remember, let's try to remember I feel funny being a representative for all the public, you know, I don't think that's fair. Anyway, remember, ultimately, all the things that are wrong with the system that we currently live under, we're going to have to address, and that this new system will get rid of most or all of that. So what I'm getting to is it has to be sellable. It has to be attractive to the public. If it's attractive to the public will vote it in, because so much of the public is not getting their healthcare needs addressed properly or in time. So thank you. It's a great team. It's a hell of a challenge, and I'm behind you all the way. Thanks.
Thank you, Lou. Whoop. Yep, that's it.
That's okay. I would like to remind the committee members that there's actually 3 questions of homework we'd like you to noodle on between now and next time. One is the IT blueprint. If you have subject matter expertise or other questions, please email Mimi. Then there are 2 bits of homework in regards to pharmacy and therapeutics. What pharmacy capabilities should be in place at the time of launch, and what pharmacy functions should remain delegated versus administered directly over time. Think about these, write down your thoughts, and bring them to our next meeting. Take with you my deep gratitude and respect for all this hard work you've done. Thank you, everyone. Tune in to watch the board meeting.
Thanks, everyone.
Bye-bye.